Oh, we're not driving G.
The meeting was actually good. Yeah.
Right. Welcome back.
We didn't meet.
So how did the test go compared to the first time you took it? A little bit better?
Can you
Right.
guys hear him?
Yeah. Can you hear us?
Well, don't say.
My alarm set for 14:50, just so we don't go over too much.
Perfect.
I believe I have enough material to cover the whole hour. We'll find out.
If not, you're gonna have to dance for us.
We'll see.
Better. I feel like you can see that.
Okay. So I'm gonna pull up all of these here.
Are you all okay with it?
And has anybody ever seen
If he
the
says,
chronic illness trajectory?
we'll just pretend we can't hear us.
So the photo looks the same in different websites and books. So we're going to go over some of these here. There'll probably be a test question on this slide. So we talked a little bit about linear, nonlinear patterns in complex healthcare. Sort of the same could be said for chronic illness trajectory. It's not a linear path. Sometimes it goes down, sometimes it goes up. Sometimes things go down really quick, kind of alters. So we're going to start with onset and diagnosis. So this is where the patient presents with an issue, some kind of sign or symptoms, sees a provider, and obtains a diagnosis. They usually do some kind of diagnostic procedure, including medical tests, imaging, consultations with specialists to confirm a particular diagnosis. The patient experience, they often feel anxious or uncertain about their health and their future, which is pretty easy to see. The nurse role on this is to provide emotional support, and we're usually pretty good at that. Clear communication and education about the diagnosis and the process. The initial adjustment. So the patient with the newly diagnosed chronic illness has an adjustment period, and that's different for everybody. Key points, emotional response. They may have a range of different emotions, including shock, denial, anger, or sadness. Information overload. So they're thinking about this diagnosis, what it means. And then they're receiving a lot of information by verbal, written information from any of the healthcare providers. So they could be overloaded and not really taking in a lot of information. Support systems, the role of family, friends, and support groups become crucial at this point. And the nurse's role is to help patients and families understand the diagnosis, provide education on illness, and connect them with other resources. The stabilization management starts with developing a treatment plan. That's where interdisciplinary teams come in. Could be dietitians, other providers. The development, implementation of comprehensive treatment plans. This includes medications, therapies, and lifestyle modifications. Routine monitoring, they'll be seeing their provider often. Regular follow-ups and monitoring of symptoms and treatment efficacy to see if a particular treatment is working. The nurse's role in this is to educate the patient on self-management techniques, monitor their progress, and adjust the care plan as needed. We go down to adaptation and integration. Lifestyle adjustments. So they need to make necessary changes to accommodate their illness. I could range from having to use a cane or supplemental oxygen, any other medications. exercise routines, dietary changes. That's kind of a big one. Psychosocial adjustments, addressing emotional and social changes or challenges. And maintaining relationships, finding new ways to engage in activities. Independence, what we strive for most of our patients if they can. To kind of live with their diagnosis as independent as possible. And the nurse's role in this would be to provide ongoing support, resources, and education to help the patient adapt to living with that particular chronic illness. And decline and progression. And sometimes these can kind of go back and forth. This stage involves worsening of the illness or development of other complications. Symptom management, managing worsening symptoms and preventing complications. So they may have more emergency visits, or if they can get into their provider, more provider visits. Advanced care planning, that's discussing planning for potential future health issues and end of life preferences. And this is kind of where we can help with advanced directives at this point. Emotional support, providing emotional and psychological support to the patients and their families as they cope with this illness. And the nurse's role would be to monitor patients closely, adjust care plans as needed, because they're all individualized, so it's going to look different. Support patients and families through difficult decisions and changing in their health status. And then palliative end-of-life care. We're going to talk extensively about that next week. But palliative care emphasizes relief of symptoms, pain and stress of illness, providing quality of care, or quality of life. Quality of care should always be there. Or hospice care, especially in their final stages of life, within 6 months. Family support, supporting the family members emotionally, and helping them with practical aspects of caregiving and decision making. And the nurse's role in this, to provide holistic care that addresses physical, emotional, and spiritual needs, ensure the patient's comfort, and support the family through the end of life process. And we go. So we're just starting out. Maybe you're counting down the hours. Comorbidities in chronic illness and acute exacerbations of chronic illness. So comorbidities, an example, that's other diseases that coincide with what they're diagnosed with their chronic illness. The patient with diabetes also develops chronic kidney disease. A person with obesity and sleep apnea. Patient with depression, chronic back pain. So those kind of all go together. Someone with rheumatoid arthritis who also has osteoarthritis. Acute exacerbations. Have you heard the term exacerbation before? Probably in the clinical setting. Patient with heart failure has sudden episode of shortness of breath after missing medication. Or it could be extra activity that there. A person with Crohn's disease experiences a flare-up after eating triggering foods. Someone with multiple sclerosis, see if I can say that word, has a sudden worsening of mobility after stress. And a patient with chronic bronchitis develops severe cough during a cold infection. Hypertension is kind of a big one. And they could have high blood pressure, also diagnosed with type 2 diabetes. coronary artery disease, narrowing of the coronary arteries, has recurring chest pain, peripheral artery disease, and a patient with leg pain due to reduced blood flow caused by plaque buildup, heart failure. And we talked quite a little bit about that in wintertime. A person with a weakened heart, unable to, causing fluid to build up. Metabolic syndrome. Type 2 diabetes with high blood sugar, struggles with weight management. And obesity, the individual with excess body weight has increased risk for developing hypertension. So those are examples. I don't want to go backwards. Mental health disorders. We're going to talk more specifically about these week 7 and 8. Often they'll have depression with whatever their chronic illness is. So a patient with diabetes feels persistent sadness and lack of motivation, making it harder to follow prescribed treatment plans. Anxiety. Anxiety is relatively common with chronic illness. As someone with COPD currently experiences panic and fear, especially during flare-ups, which worsen their ability to manage their breathing. Musculoskeletal disorder, osteoarthritis. A person with knee osteoarthritis struggles with daily activities like walking and climbing stairs, leading to reduced physical activity and weight gain. You can see how some of this stuff comes together to make things a little bit worse for them. Chronic pain syndromes. A patient with fibromyalgia suffers from constant widespread pain, which complicates their management of other chronic conditions like hypertension or diabetes. Sudden worsening symptoms, we kind of covered that. There are triggers. Infections, one of them. A person with asthma experiences a sudden worsening of symptoms after contracting some kind of respiratory issue like flu or COVID. A patient with COPD has an exacerbation due to chest infection, causing increased. They usually have to be seen in the emergency department for that. Stress is a big one. Someone with heart disease experiences a flare-up of chest pain or angina during periods of emotional stress or physical stress. Non-adherence to treatment is relatively common. A person with diabetes experiences a spike in blood sugar levels after skipping insulin doses. A patient with hypertension has a sudden increase in blood pressure after forgetting to take their blood pressure medications. Or changes in environmental conditions. A patient with COPD experiences worsening symptoms due to a cold snap or a colder air triggers breathing difficulties. Someone with arthritis experiences a flare-up of joint pain during a period of high humidity. And covered a little bit of this, but some examples would be exacerbation of COPD. Patient experiences worsening breathing due to and cough due to exposure to infection or cigarettes or smoke, any kind of smoke. DKA in diabetes. That could be a big flare-up. A person with diabetes develops DKA after missing insulin doses, and that could be with a number of different reasons, resulting in severe dehydration and high blood sugars, and they usually end up in the ICU for that. Acute heart failure exacerbations. Patient with heart failure suddenly experiences buildup of fluid in their lungs, causing severe shortness of breath and swelling in the legs. And acute flare-ups of autoimmune disease. Lupus has a sudden flare-up of joint pain, fatigue, rashes following exposure to a lot of sunlight or some kind of infection. Relationship between comorbidities and acute exacerbations. Some of these though. So together, a patient with hypertension and COPD is more likely to experience sudden respiratory exacerbations, especially during infection. Acute exacerbations can precipitate or worsen comorbid conditions. A diabetic patient experiencing DKA may also see worsening of kidney disease due to the dehydration and stress on the body. And you'll see that relatively regularly in the ICU with DKA patients, especially if they're advanced diabetes. Effective management of comorbidities is crucial for preventing and minimizing the impact of acute exacerbations. A person with heart failure who manages their diabetes well is less likely to have acute exacerbations and complications from both conditions. This is not the end of the presentation. This is just the conclusion for that. I forgot to do it. So we want to look at a holistic approach. A patient with diabetes and heart failure benefits from addressing both situations concurrently with lifestyle changes like diet and exercise tailored to improve both glucose control and heart function. Comprehensive care plans. Care plan for a patient with COPD and hypertension includes medication, smoking cessation, blood pressure monitoring to prevent both respiratory and cardiovascular events. All right, so we're going to transition of levels of care. Any questions before we go to this topic? Sorry, Curry, I can't hear you. But we'll fix that. So transitions of levels of care start with introduction. I'll let you read this. It refers to the process of moving the patients from one healthcare setting to another. That's either in the hospital or from one hospital to another specialty hospital. Let's see. Of care concept. You have primary care, secondary, tertiary, and then quaternary. I haven't said that word much. Primary care is basically seeing your family doctor or nurse practitioner for routine checkups and management of high blood pressure. And you'll want to know a little bit more on this slide for later. Secondary care would be a patient with diabetes sees an endocrinologist or a specialist for treatment to manage their blood sugar levels. Tertiary care, that's hospital setting. Person with heart failure is admitted to the intensive care unit for advanced treatment following severe illness. And then quaternary care is like a specialized hospital, not just a unit, because ICU would be a specialized unit in a hospital, but sending them to a hospital that performs certain procedures that main hospitals don't. That makes sense. So like going from a hospital where a patient is requiring a trach and ventilator 24/7, they could be sent to a place called like Vibra in Portland. So that would be considered voluntary. I don't know if you've heard of Vibra, but they take patients that are on ventilators. So transitions, we have a few different ones. We have planned, unplanned, and gradual versus sudden changes. So planned, an example would be a patient is discharged from the hospital after a scheduled surgery, such as a hip transfer replacement. The hospital arranges home health services for physical therapy, or they arrange with physical therapy to come. Another example would be an elderly patient transitions from long-term facility to an assisted living community with that care plan established before the move. Unplanned would be a patient is rushed to the emergency department due to some kind of injury, or an elderly patient suddenly develops a stroke and is admitted to the hospital without prior notice, requiring urgent interventions and rehabilitation planning at that point. Gradual versus sudden changes. Gradual, patient with chronic heart failure experiences slow worsening symptoms over months, leading to a planned move from home care to hospice services. And that would be sort of an extreme version. A sudden change would be a person experiences heart attack unexpectedly and needs immediate hospitalization, leading to sudden changes in their care plan. Factors. Patient factors. Some examples. These would be strong family involvement in care, limited income for housing conditions, high health literacy, proactive patients, and then you have the low health literacy, non-proactive. I don't know if that's a word or not, but it is now because it's recorded. Or no family support and they're isolated. Healthcare systems. Hospital provides care coordinators. Insurances deny necessary treatments. Limited access to rehab facilities. And I've seen that when we're trying to move patients from the hospital to the rehab. Sometimes it takes a long time. Outdated hospital transition policies. Interprofessional collaboration. Examples of these would be nurses, social workers communicating well, or any other member of the hospital team. Poor doctor to therapist communications. Seamless network across care teams. Disjoined transition planning. I give a little bit of good and a little bit of bad examples here. Common transitions go from a hospital to a skilled nursing facility. So after they receive acute care at the hospital, some patients may not be fully ready to come back home. So they may be transferred to a skilled nursing facility for additional rehab. Skilled nursing facilities provide round-the-clock care and help patients recover from surgeries or injuries. Setting allows the patients to regain their strength and mobility and independence under supervision. Now we can go from skilled nursing facility to home. And sometimes they go from skilled nursing facility to longer term care. Once the patient has regained enough independence and strength, they may transition back home. However, returning home requires support services to continue recovery and prevent readmission to the hospital. Some of these services might include home health aides, assistance with daily living activities, ensuring the patients remain safe and supported while adjusting to the outside of the facility. We have home to rehab center for these patients who may require more intensive therapy than what can be provided at home or skilled. A move to the rehab center may be necessary. Rehabilitation centers specialize in patients or helping patients recover from severe injuries, surgeries, or illnesses that affect mobility and function. They offer targeted physical, occupational, and speech therapies. Then we have the rehab center to home with home health services. Once the patient has completed their rehab stay, they may return home. However, some may still need ongoing support to maintain their progress. Home health services offer a way for the patients to continue to be independent and then receive the care at home instead of the hospital. At-home care would be a bit cheaper than having them readmitted to the hospital. That's it for that. Nursing roles. We have a few, and this is not an extensive list, just a partial. So assessment's big in nursing. Gotten to practice that a lot in clinicals. So you evaluate patient's discharge readiness, identify patient care needs, assess patient home environment, and make sure it's safe, determine patient's mobility limitations. And you'll see some of these concepts in winter term when we go over a lot of simulation type stuff. Education, that's big. Assessment and education. Teaching the medication management strategies. Explain post-surgery self-care techniques, because we want them to be as independent as possible. Educate the family on wound care. Instruct patient on symptom monitoring. Coordination. We do a lot of coordination in the hospitals. Coordinate discharge with the care team. Definitely takes a village. Arrange home health services. Communicate with physical therapy and collaborate with social workers or any other part of the team. Advocacy. Nurses are big in this department. Advocate for the patient's home care needs. So if there's something that's not ordered, that you assess and determine that there should be something added to the care plan, you can mention it to the care team. Ensure the patient's medication preferences. And some will say, you know, I've been on this medication that made me feel this way. Can we try this? So listening to that, giving them autonomy to make those decisions, and then we could bring it to the care team to see if we can make that happen. Speak up for the patient's financial concerns and support patients' post-discharge decisions. Not there to make those decisions for them, but we want to work with them because they are part of the healthcare team. Challenges. Communication barriers. One could be miscommunication between teams. An example of the lab results not shared with the primary physician. Patient must understand discharge instructions. One example would be patient skips follow-up because they thought it wasn't good. Incomplete handoff between providers. Example, ICU nurse forgets to mention an allergy, which should be on their EHR, but in report, it's good to mention any allergies they may have. Family is unclear about care plan. An example would be a family unsure about a particular wound care instruction. So clear communication is vital for these patients. Medication management. One challenge could be incorrect medication reconciliation at discharge. That should happen when they're admitted and when they're discharged. An example would be the patient discharged with the wrong dose. Patient unsure about new prescriptions. An example would be the patient doesn't fill the new prescription. Most facilities are really good at calling the pharmacy prior to discharge to make sure those medications are filled at least. Overlapping or missed prescriptions, a patient takes both old and the new medication. So it's vital when we're discharging patients to make sure those are reconciled. If they're on Lasix 80 milligrams daily, and it's changed to Lasix 40 milligrams daily, we want to make sure they don't take both. So getting rid of the 80 and making sure it's extremely clear is very helpful. Care coordination issues, gaps between hospital and rehab care. Sometimes that happens, sometimes a full report isn't given. Rehab doesn't receive patient transfer paperwork. A delayed home health service initiation. An example would be the home nurse visit scheduled a week late. Poor follow-up appointment scheduling. Patient waits too long for a specialist referral. Fragmented care between providers. Patients, cardiologists, and general practitioner don't really communicate. And not like a lot of this happens routinely, but these are just possibilities of what could happen. Cultural and linguistic differences. Language barriers hinder discharge instruction or education. A lot of facilities have a lot of different languages they could use for their written discharge instructions. Language barriers can hinder, I already said that. Hospitals, their patients don't understand post-op instructions in English. Cultural beliefs affect care adherence. A patient avoids recommended treatment due to religious belief, and we're there to support them on that. Lack of interpreter for non-English speakers. I think it's there's a law now that hospitals have to have some kind of interpretation system. Spanish-speaking patients cannot ask questions. A misunderstanding due to cultural norms. Family decision-making practices are overlooked. And financial constraints. The patient cannot afford necessary rehab. So the example would be the patient skips rehab due to cost. Insurance denies post-surgical or post-discharge services. So the patient, a home health aide, not covered by insurance, and they probably don't want to pay you. Limited funds for medication or equipment. So the patient may not want to pay for a walker or particular medications. Lack of access to transportation for follow-ups. An example would be the patient misses follow-up appointments due to no ride. I believe a lot of communities have some kind of ride share thing for medical appointments. Now, I can't recall if Coos Bay does or not, but a lot of other places do. Strategies for successful transitions. So having a standardized process helps. Checklists and protocols that ensure transitions between care settings are consistent and thorough. By following standardized process, healthcare teams can avoid missing crucial steps in the care plan, such as ensuring proper medication reconciliation. That's a big one. Or completing particular details of discharge instructions. Interdisciplinary rounds. Regular interdisciplinary rounds, and a lot of hospitals have adopted this. bring together all the members of the healthcare team to discuss the patient's care plan and transition strategies, promotes open communication and collaboration among nurses, physicians, social workers, therapists, and any other healthcare provider on the team. These meetings allow problem solving and adjusting care plans based on the patient's current condition and anticipated needs. Sometimes we can anticipate what they're going to need in the next care setting, ensuring well-coordinated transition. Patient education, provide clear, concise, and comprehensive patient education. This means kind of being at their level. So they may not understand a bunch of really big medical words. So we have to kind of bring that down a little bit. Should be tailored to the patient's health literacy levels, like I said. And then we have technology utilization, leveraging our EHRs and telehealth services can streamline communication between healthcare providers and facilities. Allows real-time updates. So the second we put something in the EHR, it's there for anybody to look at that has access to it. Making it easier to track patients and their conditions. Their plans with telehealth provides opportunity for virtual follow-ups. And see follow-up. Ensure that patients receive appropriate follow-up care. Involves scheduling follow-up appointments with primary care providers. Usually when we're discharging somebody from the hospital, that's one kind of a big step. So if the instructions say, meet with your primary care provider in 1 week, we will find out who that is and then schedule that appointment with the office and then let the patient know. A few ethical considerations. You're not necessarily going to be tested too much on this, but this is going to be in week. That'll still be good to know the context. So patient autonomy, that's respecting the patient's right to informed decisions about their care transition. Beneficence, and you're going to see these terms probably in a few different modules. Act in the best interest of the patients to promote positive outcomes. Non-maleficence. Actually said that right, pretty sure. Minimize harm and risk associated with transitions. Justice. Ensure equitable access to resources and care across different levels. I think that's it. Any questions? Out for a while or go?
And just to, there are no lab at all this week.
What about Monday?
Next week, yeah.
We don't have an exam, but we have class Monday.
No,
No class, right?
thankfully, if it's not on the calendar.
Double check.
You don't have to be here Monday.
I think that you asked if there's something.
There's an honor lock.
I know.
It's something that we is that like a lockdown browser, kind of like a Kaplan does it?
You took this with my.
Inevitably, I'm gonna hear.
What's where?
On the calendar.
And then you have to show the camera. Have the camera set up.
You're gonna have to do that. Oh, okay. I just saw him, I'm like, okay, like I've never seen this before. So I wanted to-